So just a couple of, I guess, one announcement. We're going to have another speaker coming up on August the 19th, Val Club with the UK Biobank. So they're going to be talking to us about how they mapped their survey data. In between that, on our meeting on August 5th, we're going to continue working on the landscape assessment survey because we've put that down for a couple meetings so we could have our speakers. So we'll do that on the 5th. So in the meantime, I haven't seen, is there anybody besides Oleg on the call who hasn't been with this group before? Just want to make sure we get everybody introduced. I see Alexander.
Well, I'm not sure whether I attended exactly this one. Probably not. Probably we talked like previously. Yeah.
Yes, I think we've talked previously. Yeah, at the other CDM meetings. I think that's where we first got acquainted.
Right.
So why don't we start with, if you don't mind, you, Oleg, and I think I saw Anna as well, if the three of you would introduce yourselves to the rest of the CDM groups, and then Oleg, you can go ahead and begin your presentation. I don't know what you're more comfortable with, is if we ask questions as you go along or at the end. Do you have a preference?
We're gonna ask questions. It's okay, we can stop.
Okay. All right, sounds good. Well, thank you all for attending and coming to present. And Oleg, I'll turn it over to you.
Yeah, okay, so let me introduce myself first. I'm Oleg, I'm Odyssey Vocabulary's tech lead, and I'm working in Odyssey Vocabulary's team for, I've been working for the last 6 years. So, yeah, I witnessed changes in the survey data handling and in general vocabularies. So, and I have the presentation regarding this today, and we also bring Anna and Alexander. So you already talked to Alexander and Anna. You introduce yourself. No, if Anna is connecting, Anna is it's a leader of our vocabulary working group. And she's been doing a lot about vocabularies, like literally every vocabulary has a touch of Anna's in the scripts and in manual work, like everywhere. So, and today we're going to discuss surveys. And I have a presentation, so let me share my screen. Can you see my screen?
Yep.
Good. So, first slide. What's the problem with survey vocabularies in OpenCDM? So the problem is that the survey vocabularies are very heterogeneous in structure, and each author and organization design surveys how they want to see it, like introducing multiple semantic duplicates, question or value or combination of them to all vocabularies. Why aren't we happy about this? Because they bring a lot of standard concepts that are very often misused by OMOP users. Just a little bit of statistics. In Loink, it's around 11,000 standard concepts. In PPI, it's more than 2,000 standard concepts. In UK Biobank, more than 4,000. That's really a lot. And we aren't happy about this because PPI should not be a target for your mappings. And people see standard answer asthma in Loink or in PPI, for example, and think that this is a proper target for condition asthma. Unfortunately, that's
I'm
not
sorry, Oleg,
true.
to interrupt.
Yep.
Would it be possible for you to put your slides in presentation mode? I think they're coming out a little small for people who might be on their laptops.
I forgot about this. Sorry.
Perfect. Thank you.
Yeah, no problem. Yeah, that's a problem statement, and also this, as a result, the survey vocabularies, they violate vocabulary principles our vocabulary system is built on. And the first one is a unique standard concept. So for each clinical entity, for each clinical event, for each fact, there is only one concept representing it. Well, as I said, asthma is an example. It is present in Loink. It is also present in SNOMED as a standard condition in SNOMED. There should be only one standard asthma, only one standard diabetes. Also, there should be no flavors of null, and flavors of null, some concepts like unknown, not reported, NA, like not otherwise specified, etc., etc. So they really bring nothing to your data, and we call them flavors of null. And now they are mostly standard concepts coming from the survey vocabularies. Next principle is no negative information. So no concept should represent absence of evidence. This is a general CDM rule. And the last one is a little bit tricky. No timing. So temporality should be enforced from the data and not rely on the vocabulary. So you should not query your vocabularies looking for the ways to represent something like this. Have you had acute myocardial infarction during the last 10 years? Yes or no? So these 10 years should not come from the vocabularies really. So they should be in your data. You should query specific fields for the dates. So no timing in vocabularies. And just a little bit more about our examples. So for I used asthma previously, now it's diabetes. And you see that there are multiple diabetes mellitus on vocabularies. There are only 4 of them here for simplicity, but there are much more in the real data. You see that diabetes mellitus is a standard condition here. It's a green standard concept coming from the SNOMED vocabulary. There are also diabetes in ICD-10. There are also diabetes in ICD-9-CM, and we are doing a good job here. They are all red. They are all non-standard with mappings to this standard SNOMED. But there is also diabetes mellitus as a long answer. So they're very often misused and mistreated in OMO vocabulary. So we could not map them one to another, and I will later explain you why. One day we actually tried to standardize them by mapping one to another, and now we can see it. And it seems to be the pretty much the very same information, but in fact, what we realized that we could not standardize them. So couple of examples here. When did you quit smoking? Even if the answer is the same, the question is the same, the list of answers are very often different in different vocabularies. So for example, 16 years or younger in UK Biobank, in childhood PPI, and 10 years or younger, and also 11 to 16 years in LOENC. So can we treat childhood like up to 10 years, up to 16 years? So how can we standardize them, even though you can see that the question is all the same, but the answers are very much different. So how can we decide if they are the same thing? In fact, we can't, and we asked for your input years ago. We see that this post is from 2021, and now probably it's a good time to solve this problem. We introduced and we discussed multiple solutions. We want to make this vocabulary standard. We wanted to make them non-standard. We wanted to introduce something new like precardinated pairs. We also want to introduce new fields. So there are multiple discussions going simultaneously, and there are also multiple decisions for us to make. More examples. So let's look how it's currently done in different vocabularies. And in this particular case, it's a PPI vocabulary. Including yourself, who in your family has had asthma, select all that apply. That's a question. This question has an answer, including yourself, who in your family has had asthma. So it's kind of a semantic duplicate. It's a combo of answering the question, because the real answer is daughter, and the question is including yourself, who in your family has had asthma. So this answer from PPI vocabulary is actually a combination of a question and an answer. And this answer has mappings to 2 entities, like a family history pertaining to with context pertaining to daughter, and maps to value asthma. So you see that that it's a very specific way to handle the data, and the answer really has to be question specific, because we very often see how different questions within the vocabulary share the answer. So in this particular case, The answer is question specific, is kind of a duplicate, but in other vocabularies we can see that there is only one yes in the whole vocabulary. There is only one no, only one daughter within the vocabulary. Another example, same vocabulary, but the structure is very much different. So the question is here, and some of the answers are standard concepts without the mapping, and some answers has mappings to another answers in different vocabularies. More examples of answer to answer or answer value. We can say that to entity mappings coming from PPI and from NACR values. You see that they're all heterogeneous. We can map them to different following answers, so to different measurement values. In NACR, we map them to events, actually. And now, the most recent example. So the most recent example is UK Biobank. And here we simplify things. Instead of mapping them, we tried alternative approach. So the question is, has the doctor told you that you have any of the following problems with your eyes? Do you think this should be a standard concept? Like, probably no. So this is a question, but we want to map it somehow. And this question, it has answers, and the answer is, let's take one example. Let's take diabetes-related eye disease. So the question, the answer. So what we've done, we've introduced a combination of question and answer as a separate concept. We called it pre-coordinated pair, and it combines a value of a question and an answer. So it combines the clinical meaning, the clinical entity of these concepts. So in this particular case, it's eye problems, disorders, diabetes-related eye disease. It is connected to answer. It is connected to question. So everything is connected. And this pre-coordinated pair, it has mappings to the real events, like disorder of eye due to diabetes mellitus. And they are non-standard. So they are very generic. We use them in OMAP, but the authoring organization will probably never know about this concept class, about these concepts. So this is how all this developed. In vocabularies originally, we've done only string mappings. So we try to standardize something. So we try to standardize answers. We try to standardize questions. You see it goes this way. And now we're probably somewhere here. So we introduced these pre-coordinated pairs during our UK Biobank release, and we use them to these days. So it's pre-coordinated pair to event mapping. And at the bottom of the slide, you can see the CDM level harmonization. And in CDM level harmonization, we tried to introduce survey specific tables in CDM 6.0. Obviously, it didn't work. It didn't work at all. So now we are talking about other steps. And today we want to discuss value source concept ID field. It's kind of a new field we want to introduce to help handling the survey data in the vocabularies. And there are also more topics to discuss, like wide mapping table, logic relationships groups, probably not for today. So in general, what's our proposal? We designed it for the observation table, because observation table is a place to store the surveys, but it also the same applies to the measurement table. You can see here there are 3 blocks. So this purple, can I see purple? This purple block is for source values. In this particular example, it's including yourself, who in your family has had asthma, so it all that applies. So you already saw this. It's just how the data is represented in the source. And the value of this is the value of this answer is a daughter. So these fields already present in observation table, and everything's fine with them. So the green fields, it's standard fields. So they only intended to be used for standard concepts. And in this particular case, it's observation, concept ID, family history with explicit context pertaining to daughter, and values concept ID, asthma with the disease. And blue in the middle is a source concept ID field. So one of them is already present. It's observation source concept ID. It should be populated with a concept ID of the question if the question is present in the standardized vocabulary. So this particular case, it should be these numbers. It's a concept ID for this question. But this field is missing. It's actually the same, but for the answer. So we just want to add this particular field. And if you go through the CDM specification, there would be source concept ID fields for everything, for procedure, for condition, for measurement, for observation, but not for source concept, for value source concept IDs, not for the values. Is that a problem? I mean, do we violate something by this proposal? Or is there anything wrong with it? And the answer is tricky because partially we can say yes, and in a current, but it's already happening. So that's a good news. So let's let's look into this slide. So if we map event to event and value to value, everything is straightforward. We do one-to-one mappings and structure fits semantics. So what's in your data, what's structurally a value, like a result of a lab test, or in that particular example, it was a daughter, so who has this disease, right? It's a value in your source data. And if you map it, if you put it into the value in observation table, it's straightforward. It's right. It's everything is working. Like events go into event to observation concept ID field, and value is going to value as concept ID field, and source fields are populated respectively. But there are other things when we map in pre-coordinated pairs, or when we map like one entity to event, we use both fields to populate only one of them in so-called many-to-one mappings, and you can see the structure is partially related to semantics, but not necessarily. In many-to-many mappings, when you use both event and values to populate both event and values, you see that there is mismatch between structure and semantics. So somehow value in your data starts to influence the event in your source data. So it's kind of strange. And most importantly, there are cases when we swap mappings. So structure is completely the opposite of the semantic. Like when event can be mapped to value, and value can be mapped to event. The good news is that it's already happening. It's mostly a theoretic exercise. It's already happening in different vocabularies, and we want to adjust CDM specifications to correspond to our mapping practices. So to summarize what we discussed today and what we will be discussing today, so we add one field, value source concept ID, into two tables, observation and measurement. We align the definition of the CDM fields with the mapping practice and expectations, because we already use value concept ID field for different things, not like it has been intended to be used. And in the future, the survey data can be modeled through the non-standard concepts. So ideally, we would like to see them non-standard, and vocabulary source structure is preserved as is. So both questions and the answers are available separately and can be queried. Both source questions and answers are accessible in CDM. It's very important, so we not lose the structure of the source data. And mappings are done through the pre-coordinated pairs where applicable, so to real clinical facts. You can still use the standard, yes, you can still use mappings, and you can still use standard fields in the tables. And analytics is based on either real clinical facts, so the mappings, or source non-standard survey data. And this is a summary of our proposal. And this is it. So thank you for your attention. Also have slide with references where it has been discussed.
Great. Thank you so much, Oleg. That was very informative and definitely a lot to think about. Some point, will you send me your slides, and then I'll post them so people can have access to the links and also review the details. So are there, unless you want to, you already summarized. So any questions, comments from the group?
So Oleg, let me clarify like the summary here. So like there is Oh, yeah, you're not sharing. Yeah. So there is a proposal of adding this field, right? And then we're saying that in the future, that will be the basis of some future steps, right? So we're not saying that is going to be like the part of this specific proposal, or do we?
Oh, it's I would say that this is a moving thing. So we do need these tables. Sorry, we do need these fields anyway. So we discussed them with we presented them. We discussed it with Claire, and yeah, she agreed with us. So this field is needed. We'll start adding it. We already drafted a pull request and everything. So this is a moving. But in the vocabulary work, when we have these fields in the regular CDM, then we can start standardizing surveys, ideally. So it's probably one big proposal that can be split into multiple small proposals.
Right, and
It's my vision.
Yeah, thank you. And probably what will make sense here is that we prepare another sort of like step of this proposal, well, when we actually explain what's going to happen next, or propose what's going to happen next, where we standardize the survey data and propose a way of dealing with that, right? Because at the moment, most of the users using them as the standard concepts, right? And we need to properly communicate that it's not going to be the end of the day. We're not kicking them out. We're still saving the survey data in CDM, but we just propose to change a way of dealing with that, right? Preserving both of the use cases and both of the applications that are available at the moment. Probably is going to be like a larger and a new discussion when it comes to the third point here.
Yeah, thank you very much. I think it's really important message. Yeah.
Thank you. And yeah, I do have a couple questions. So I think my first question is, what is the benefit or the logic with mapping to non-standard as opposed to trying to work in the standard concepts? I'm sure if I'm understanding, it's been problematic because you've got these multiple vocabularies, but maybe I'm not understanding that correctly. Could you elaborate? And then, sorry, Queen, I didn't see you put your hand on, and then you can go next.
The problem is with vocabulary principles. So this one, so unique standard concepts, and we published a paper about the vocabulary principles, and we want to discuss them more openly. It's a principle is unique standard concept. So for each clinical entity, there is only one concept representing it. And currently, we do have when we try to do QA, we realize that there are multiple like sometimes it's hundreds of very close concepts with a close meaning to each other, but one of them is a proper condition, and everything else is kind of low-end answers, UK Biobank answers, and they're very often misused in vocabularies. So we see like people sometimes submit phenotype definition with measurement values. So with the low-end answers basically as a basis of phenotype definition. So we want to prevent this. And we want to follow the structure, we want to follow the vocabulary principles, and we want to standardize them somehow. If you have all of the vocabularies, all of the surveys as a standard, you can only use your own survey. It's very hard to do some standardized research in a network level. Yep, that would be my answer. Yeah, that would be my answer. Maybe Alexander has something to add, or Anna.
Well, like in short, that is not the way the standardized vocabulary should work, right? Because the main dogma here is that we pick one that is supposed to be a standard, and all the rest are mapped to the one. And here it's not happening, and there is a good reason why it's not happening, because it's like simply not really possible to map all the variations of asking the same thing in different ways to something, right? And we say that instead of that, because we cannot really implement the principle here, instead of that, we would better make them non-standard, so they're still accessible for analysts, but not being the standard ones, but source fields, but still accessible for analysts. And then we map the data that is supposed to be clinical facts that are usually used in Odyssey research, right? So we sort of cover both of the use cases. We still preserve a way of doing this very, very specific survey research. And we also support the OMAP classic research when you actually look at the conditions and the things like that.
Okay, thank you. And I do have a follow-up question, but I want to let Queenie and Monsi go. So Queenie, why don't you go ahead and ask your question?
Yeah, thank you so much. So thank you for presenting this. I think the example of the asthma piece was helpful to kind of understand the proposal. I was wondering if it would be possible to get some other examples that are like of varying complexities. So more like categoricals or Likerts, like in the mock-up of the tables. I'm trying to understand and visualize what end users would see, and if like a light SQL statement, even a mock SQL statement to help understand where folks would kind of go would be really helpful, if that's possible.
You mean more examples here?
Yeah, because for this one, it's like it's a condition observation. So we understand conceptually what this means. But when we have surveys that have like Likert answers with multiple categories, I can't quite understand or visualize what that would look like here, or how users could find those rows of records.
It will be actually the same, because adding this field, it doesn't change how you currently treat the survey data. So you still, right now, you populate the observation source value and value source value and also standard fields, right? And this one. So do you populate them? I mean, well, normally the answer would be yes, I think. And you're only missing this one field, so it doesn't change anything. It stays the same. We only add one extra field to get more content into the tables. So we don't have examples here, but when I send the presentation later, I can include more generic or more real examples. So yeah, maybe it will be easier.
So, and I just making sure I'm understanding the answer. So, for example, if a Likert scope question like, how often have you had problems sleeping or something? And, the scale is 1 to 5, and 1 is every night and 5 is never. You would basically map the every night or never. Is that what those? So the question would be, how often do you have trouble sleeping? The response, for example, would be never, 1, where daughter is, and it would map similar to that. Am I thinking of that correctly? And then you'd have that for each of your responses, but you'd have to come up with some way to qualify like what 2, 3, and 4 meant relative to like 1 and 5. Does that make sense?
Well, if you have concept like 1 equal to never, like you have this, so it's basically the same as daughter here.
Okay.
This particular example. If you have values number, basically, if you have 1, 2, 3, 4, 5, how often do you do something? And the answer is just 2 or 5 or 6. Then you populate a different field, which is values number. But I think it's a different case. So if 1 equal to never, it will be pretty much the same. So the question will go to observation source, concept ID, and observation source value, and the answer to this value source value, like 1 never, and here will be populated with this field will be populated with concept ID of this 1 never concept.
Okay, thanks. I just want to make sure I was understanding that. And Monsi, I know you have a question too, so.
Yeah, mine is more. I actually agree. Some more examples would be helpful. So I'm trying to also get my head around how that's.
Right.
I guess
Noted.
the problem is that some of us, at least I haven't done that, assign concept ideas at that level and use it. So then maybe that's why we need to have more our hands-on to really fully understand it. But at least at the conceptual level will be helpful to have these more examples. But my question was more about what we really mean by non-standard concepts. So these are concepts that, for instance, all the connect concepts that have been the concept that Nicole have generated for the connect, this new prospective cohort study, are just considered non-standard, or what how do you define a standard? I mean, I know examples of standards you've showed there, but what makes a standard concept? Like UK Biobank generated a lot of things that they became standard. So if you can tell us a little bit more about that.
That's a good question, because we're sometimes struggling to define a standard concept. It's easier for drugs, for example. We take Eric's norm, and everything in Eric's norm is standard. For conditions, a little bit more tricky, but we mostly follow the SNOMED rule. So if SNOMED thinks that this concept is valid, then we also think that it should be standard mostly. Sometimes we add OMP extension, etc. For measurements, we think that lowing should be standard, and SNOMED also complement lowing in some terms. So for surveys, it is related to all of these things, and that's why we need to introduce mappings from surveys to some standard concepts. So as I showed in the first part of my presentation, it could not be done. So we could not standardize surveys to surveys. So we could not map one survey to some meta survey, because they could not, they're semantically different. So we could not basically standardize them. So that's why we try to map them to other domains, to conditions, so to real clinical facts, like for example, what drugs do you use? I smoke every day, and that would be a clinical fact of a smoking. So the person is a smoker. So we will map it to a condition of a smoker. And answering why the UK Biobank has lots of standard concepts is because we were missing this field. So we don't have value source concept ID now, and we haven't had the value source concept ID in 2020 when we introduced UK Biobank. We wanted to make all of them non-standard, but otherwise it would be impossible to use most of them, just because this field is absent. That's why we made them standard.
You made, so they were, so now you started working with UK Biobank, and then they had these concepts that had, you couldn't map to any standard, so you had to create a new standard. Is that what you mean?
No, if we left them standard, as you see, most of the UK Biobank concepts, they are standard because we could not map them, and we could not use them in the other way. So the only way to use them currently in the current CDM,
they were non-standard, but because there was no standard, they became standard.
So there were no standard for them, and we could not standardize them. I mean, that's a little bit different. So we could not standardize them because of some reasons. So we could not map them.
Yeah.
There, like lack of resources. That's one cause basically, and the difference is there is no good suitable target for them.
Right.
It's a little bit different. So that's why we left them standard. We would rather not doing that. We would leave them non-standard, but there is no way to use them as non-standard concepts because of lack of this field. That's
so now when the next study comes, that's not UK Biobank, like Connect, has created, my understanding, according to that definition, almost all the concepts that were newly created for Connect are non-standard, right? By definition, because nobody else is using it at the moment, only this cohort, right? So if you want to start standardizing them and we start mapping them, there will be many that you cannot map. It will be the same problem that you had with UK Biobank. So they will be able to map a portion, but there will be many that have been unique to that study that have not been created as standards yet. So what would happen then? And then there's the next study, the next study, the next study. So it just keeps building. So how is that going to work?
Well, ideally, we would like to see everything mapped. It's again another
but it won't
principle.
Map. It won't map.
They won't map. They won't.
If we map 50%, I'll have a party. It's just not going to even happen. Probably.
Yeah, we know that. We know that, but that's not that's not an excuse to leave them standard.
Yeah.
Yes,
We'll definitely try. We'll standardize, and then you have like, let's say 50% that are not standard, that you cannot find a mapping. What would you do? Would you create new standards based on those, and then the next one? So then the percentage that doesn't map will be smaller and smaller. Is that the idea? Just trying to understand how that works.
Well, we need to see them first of all, and we will not create targets. We will not create standard concepts for every UK biobank just to complement it or to have something to map to. No, we would rather create only meaningful concepts and leave everything else non-standard without mapping.
So you make that decision whether you think it's meaningful or not.
No, we'll come up and discuss it because it's really hard to make this decision. We try to
exactly.
be more transparent nowadays and discuss everything. But yeah, again, it's a lot of theory in this because we're not yet there.
Yeah. Okay. And then my last comment is related to that, and then I'm stopping. Is because we have somebody here from all of us, right? It has created a lot of concepts too. Are these standard or non-standard?
So they're mostly standard.
Standard. Okay. So it's the same process as the UK Biobank. It has gone through the same process.
Now, I would say the process is different because most of the examples I showed with the different mapping approaches, they're coming from the PPI vocabulary, so All of Us initiative, and UK Biobank is more standardized in the approaches. So we specified which part of UK Biobank is standard, which one is not standard, which has mappings, etc., etc. There are multiple rules in UK Biobank. For example, if but it's again, it's internal for UK Biobank, and it's all in the documentation, so you can read about this. UK Biobank, if the concept has only answers like 1, 2, 3, 4, 5, like only numeric answers, then this concept is non-standard because it can be used as non-standard. You have value as number, you can use this, and it doesn't matter if your concept is standard. But if the answers are like here, daughter, they could not be used as non-standard because of lack of this field once again. So that's when we keep them all standard. So it's kind of different groups. I can send in chat. I can send the description of the different groups in the UK Biobank vocabulary. So it's all there in the documentation.
That'll be very helpful. Thank you.
So the reasons why we sorry, I just wanted to add to the answer. So the reasons why we left something standard are different, right? So the design of PPI is like one story, UK Biobank is another step, and the design is a little bit different. But what is common is that both of these vocabularies has lots of standard concepts. And with this new proposal, we actually want to turn them into the non-standard domain, right? So, and we're starting talking to people, right? So we're talking to all of us, we're talking to other people in terms of whether they believe that that is acceptable. And I think we have like a couple of positive feedbacks, right? So, and maybe, if I'm not mistaken, Brandy's here from, and she can actually talk about it, right? Whether they believe that that is acceptable. We can implement this solution going forward. What should be done if we do that? What are the consequences? So that is what we want to discuss as a next step, right? Now we're introducing the field that actually enables us to talk about the new approaches, and the next discussion will be about the actual implementation.
Right. So I guess part of what I'm trying, because so we've seen we have these separate efforts, different efforts. All of us in UK Biobank have had different approaches to trying to get the survey data into OMOP. But ultimately, if the group adapts the principles that you've laid out, our goal is to make surveys interoperable, right? It just sounds like we're having a lot of these one-off efforts, and it's great everybody has this survey interest in OMOP, but it doesn't sound like we can work and play together yet. We're not at a place where these surveys can be interoperable. Is my understanding correctly?
Yeah, that's right. But by saying interoperability here, I'm not saying that one can be mapped to another ones because they're really all different. We're just saying that on the structural level, we want to allow them be represented in the OMAP CDM as a non-standard ones, and at the same time contribute to the OMAP events by mapping, right? So that not only the data as is, the service data as is represented, but it also mapped to the conditions, drugs, and the things like that. So you can at the same time benefit from sort of both approaches.
I'll just say from, I was watching, and you're right. Look, this value source concept ID within all of us, we actually had an in-house version of that before it was introduced so that researchers could work with it. So that was not an issue. But I think, Nicole, maybe one takeaway is like, this is an example for all of us in UK Biobank of how those survey instruments are deposited into OMOP as a new vocabulary versus mapping to existing LOINC or condition vocabularies, which I think, to your point, is like the interoperability. If we create surveys that can be mapped to qualitative assessment or condition or observational standard vocabularies, we don't need to deposit them into the model directly, I think could be something we consider.
Yep. Ideally it is so. It's very different. So it's a good question if we can standardize everything, because even with our best efforts, it's only partially standardizable. So yeah, we probably need to go on a case-by-case basis. Social determinants of health, then something else, then again something else, probably. Yeah.
Yeah. So maybe start with things, that are commonly used as CDEs, your common data elements are probably, things that are asked across a lot of surveys, right? Ethnicity, age, gender, sex at birth type questions that get asked over and over again, I'm guessing would probably be the low-hanging fruit that's easiest to map across surveys. And then you kind of expand to things that are more complex. And so, yeah, a lot to think about. And so one of our objectives for this year as the CDM survey subgroup is to do a landscape assessment of what all this other work that's going on. So we know we're not, trying to reinvent the wheel or, can reuse things that other people have used that might help move this more forward. So that's sort of our first goal. And that's why, we've invited you and others. Like I said, we're having somebody from UK Biobank on the 19th that will go through that process for us. And Brandy, had talked with us about all of us's process and things. So what I'm wondering is moving forward, and I don't need an answer now, but if we could all start thinking about it, how can we work together? Because again, no point in duplicating efforts or reinventing the wheel. But obviously there's a lot of overlap in what we're trying to do and what the vocabulary group is trying to do. And I'm just wondering in what ways we can work together or, coordinate our efforts.
That's a good one. What can we do together? So I think we can really define the use cases. So what do you want to study? So you probably don't want to study every single question in UK Biobank, and not every, so maybe if we define use cases, then we can split into buckets and then tackle it one by one. I would say that, but really we need to think about this. In my opinion. Alexander, do you have something else here to say? How do you see?
Well, if people just do different implementations of OMAP CDM in this field, they will just need to get back to the working group and show what did they do, right? So that we can discuss it publicly and take the best of the approaches and then align it and come up with something that is going to be a standard for everybody.
Yeah, they don't have a standard.
Yeah.
Maybe.
I mean, that's the dream, right?
Well,
that we get to to the standard?
Well, not in the sense of having the same sort of survey instrument, but in the sense that the methods and the approaches are the same. At least in this sense, that we have the same structure and the same conventions, not the content, obviously.
But that basically people are approaching mapping in a best practices sort of way, so that if you can build out from there, possibly get to a point of interoperability if groups are taking the same approach. Okay.
There's now a mechanism of community contribution, so you can just send us mappings if you think that they should be done. Yeah.
And then another question. So we've also been discussing use cases on our end, and I think it would be great to pull these, different kinds of use cases together and see how those would help us move forward with coming up with best practices or approaches. But one of the questions I had in terms of sort of this practice of mapping to non-standards, because that's what works with the data. How do you see this working with projects where people want to validate or look at, the information that's gathered through EHR versus in a survey? So if a patient or participant reports having diabetes, validating that their medical record also has diabetes, or they have similar information about history. And of course, one of the things we'll be dealing with in Connect, and I'm sure in all of us, and other studies, is participants who move around, right? So they, their most recent provider might not have that history of diabetes. And so you want to see what, medical information is being transferred. So in some way, you're going to end up having to go back to looking at your survey answers with standards in the EHR. So I just kind of, I guess, wanted to get your thoughts on that.
Oh, well, if they match each other, though, there should be no problem, right? But we have types for this, so it's basically the same record coming from different data sources. So we can match types, and I don't think that it should be solved within the vocabularies. So actually, you need to do this during your ETL and probably create some custom logic to compare the data sources, and then if they match, you're good. If they're not matching each other, then it's probably need to filter some data out. That would be. But it doesn't sound like a vocabulary problem. This particularly.
Let me clarify. Are you saying that even if something is not mapped to the condition, because it's not just a simple fact of having a condition, you're asking whether there's a way to somehow link this sort of concepts with the condition, or did I get it wrong?
Yeah, something like that. So if what is in the survey it maps to a non-standard, but there should be a corollary to it in the EHR that you want to see is there, but that's put in as a standard. And like Oleg saying, this is not necessarily a vocabulary question, but this is definitely a use case that has come up. And so, are there disadvantages with a non-standard approach? Like, should we try to get as much map to a standard that already exists as possible, and then you only use the non-standards when that's not possible? Is that, and then for those, I guess you have to figure out if you can find a corollary of the EHR.
I mean, I can just say that is what we've seen done, like for all of us. So if there's something, a non-standard maps to a standard, it's got both assigned. I mean, you're using the standard. And so we could tell a researcher you could use the standard condition, the SNOMED, to ID anybody who has this diagnosed condition, regardless of whether the source is EHR or the survey. And then you could use the source field to see where that was derived from an ICD, so clinical versus the survey. I don't think the proposal is that we wouldn't have anything mapped to a standard.
Okay. Oops. Yeah, that's helpful. Thank you. And thank you both, Oleg Alexander, for sharing the work you've been doing. I really hope we can have continued discussions and sharing. We do plan to share with the community the results of this landscape survey. So hopefully that will be beneficial to both groups, but definitely want to consider, think about it and continue the conversation about how we might be able to work together and combine resources to get to where we'd like to be. So since it sounds like there's a lot of overlap. So I think we're down to, we've got about 7 minutes left. Are there any other questions or comments before we close the meeting? All right. Well, thank you again for presenting, Brandy. Thank you for chiming in with some of the all of us perspective. We'll get some of the UK perspective in August. And then if you had a chance to, some of the ideas and questions we're considering for the landscape survey are in the bottom of today's agenda. So between now and the next meeting, you can look over that. And on August 5th, we'll talk about trying to flesh out that survey so that we can share it with the group and start gathering some data on what different groups have been doing to manage their surveys. So thank you again, everybody. Have a great rest of your
Thank you.
week.
Thank you.
Thank you very much.
Thank you all.
Bye bye.
Bye.